welcome everybody to the Maddie Revolt's Vision 2024 series of patient and family educational sessions on bone marrow failure syndromes. So I'm Amy Coote and I'm the CEO of Maddie's Vision. I would like to start by acknowledging the traditional owners of the land on which we are gathered here this evening. So for me, I'm on the lands of the Wurundjeri people of the Kulin Nation. I'd like to pay my respects to their elders past and present, and also extend that respect to other Aboriginal and Torres Strait Islanders who are here with us today. As many of you know, Maddie's Vision is the only organisation in Australia driving bone marrow failure syndrome research, advocacy, education and support for patients and families. We are incredibly proud to have established the Australian first Centre of Research Excellence in bone marrow biology. We've now funded $8.8 million across 36 cutting-edge research projects and have multidisciplinary collaborations with 24 leading medical research institutes, hospitals and universities around Australia and internationally. We bring together the scientific community to create opportunities for collaboration and innovation in bone marrow failure syndrome research that otherwise would not have been possible. Maddie's Vision is also the source of support for bone marrow failure syndrome patients and families through our telehealth nurse service and our new peer support program. We offer a patient and family-centred service from diagnosis throughout treatment, during long-term follow-up and even bereavement. We now have supported over 100 patients and families nationally and invite any of you here tonight who have not connected with these services to please reach out. We are here for you when you need us. Maddie's Vision also continues to advocate on behalf of bone marrow failure syndrome patients and families at both state and federal government level. I personally have invested a significant amount of time reaching out to members of parliament, relevant ministers to speak about bone marrow failure syndromes, ensure we can secure future funding and ensure that we are able to continue supporting the patient and family community. So our program this evening features presentations from two leading experts who will provide an introduction to Blackfan anemia and an overview of the latest research and treatments for this condition. Following their presentations, we'll have a 30-minute Q&A session. So we really encourage you to please get involved and ask the questions that you do have. This is a safe environment and we're really proud to have been able to provide this for you to ask from these incredible experts. But thank you to everyone who has pre-submitted questions prior to today. So our speakers have endeavoured to cover these in their presentations tonight, but if you'd like to expand on certain topics, please do let us know during the Q&A. So it's an absolute pleasure to introduce our first presenter, Associate Professor Amy George. So Amy is a group leader in the Genome Science and Cancer Division and leads the ANU Centre for Therapeutic Discovery at the John Curtin School of Medical Research at the Australian National University in Canberra. Amy will be presenting tonight on science and the latest breakthroughs in Blackfan anemia. Thank you so much, Amy, and over to you.
Thank you, Amy, for that lovely introduction. I'll just share my screen, so just bear with me for a moment. Okay, hopefully everybody can see my screen. Please yell out if you can't. No, okay, so it's a delight to actually be here tonight to talk to you about the science which underpins Blackfan anemia. I also wanted to acknowledge, celebrate and pay my respects to the Ngambri and Ngunnawal people of the Canberra region and to all First Nations Australians on whose traditional lands we meet, learn and whose work and cultures are among the oldest continuing cultures in human history. So I do want to fully disclose that I'm a laboratory trained scientist, I'm not a clinician. So if you do have any specific questions at all around clinical related items, please bring up in the chat. I'm sure Patty can probably answer some of those questions, but I'm very happy to talk about the science. So all living species need proteins for growth and function. They underpin so many different important processes in our bodies. We have bacteria right through to humans that need proteins for function. And so they form key processes such as growth, development and tissue repair. And so proteins are synthesized by structures called ribosomes, and these ribosomes are located in all cell types in the body. There are around 10 million ribosomes per cell in any given cell in our body, and we have trillions of cells which make up our bodies. So you can imagine there is many, many, many ribosomes. And some cell types, such as a bone marrow, actually have a requirement for more ribosomes because they actually need more proteins to be able to conduct their function. So ribosomes are these big factories in the cell. So think of them as a factory itself. And so what they do is take amino acids and form these into proteins. So we have around 20,000 different types of proteins in our cell that we need for all of our different functions, but we need some instructions to be able to make these proteins. And so to do that, these instructions are located in our DNA, within our genes. And so every time our bodies need to make a specific type of protein, we need to look at the recipe book and make a copy of that recipe. This is through messenger RNA or mRNA. And so along with the amino acids, these messenger RNAs enter the ribosome and then form these proteins. So ribosomes themselves are actually formed out of proteins. So these are ribosomal proteins that form what I like to think of as being the bricks of these factories. And then ribosomal RNAs, which are kind of like the mortar that holds these ribosomal proteins together. So we have roughly 80 different types of ribosomal proteins in our bodies, and they form structures that look like this. So this here is an ADS ribosome. So it's a ribosome that's just about to make protein. And so in teal here we have, this is a ribosomal RNA. This is a crystal structure that we would do in the lab. And so each of these individual colors represents a different ribosomal protein. So just do a little bit of a scooch around. So these are actually massive structures within our cells. Right, so ribosomes are made in a really complex and multi-step process called ribosome biogenesis, and it's coordinated within the cell by a structure called the nucleolus, and this is where my research is sort of focused around. So this here is a picture taken by one of my students. We take some human cells and we culture them, and we can stain for different parts in the cell. So we can stain the DNA, which is the blue here, and inside this nuclear structure we have nucleoli, which are in green. And so these specific structures actually start the ribosome biogenesis process, and this is the starting point for where ribosomes are made. And so from here, it moves right out into the cytoplasm where the proteins are actually made and the ribosomes function. So the nucleolus is important for this, of course, but it's also an important stress sensor. So if a cell determines if there's any changes in ribosome formation and function, it's actually a stress response and a behavioural response changes in these particular structures that help to elicit a specific response. So what causes ribosomopathies? So these are generally alterations in genes that are associated with ribosomes, and these alterations modify the formation of ribosomes and their function, or their function, sorry. So this could be changes in the brick structure, changes in the mortar, changes in what I call the factory workers. So these are chaperones. So they're not actually part of the ribosome themselves, but they actually kind of work to put the ribosomes together. There are also some other genes which are quite interesting, which we're still trying to understand what their function is. But these genetic changes can prevent ribosomes from being made, or could reduce their efficiency, and also change how the ribosomes make proteins. So this is a pretty it's a bit of a horrible looking slide, so I apologise, but I just wanted to show you that it is a highly complicated process. There's lots of steps and lots of different factors. But the point I wanted to make here is that with all different ribosomopathies, they impact on different parts of this process. So in the case of DBA, it impacts on these ribosomal proteins being integrated into the two subunits, the 40S subunit and 60S subunit, which come together to form this ribosome, which translates the protein. So currently the genetic landscape of DBA, which has been recently updated through the International Consensus Consortium, sorry, it's a bit of a mouthful, show that there are around 24 confirmed ribosomal protein genes, so they're all listed here, and 7 putative ribosomal protein genes. So these are new ones that have been are potentially pathogenic. And then 2 ribosomal protein chaperone genes. This includes a gene called HEDAR3, which is currently the subject of one of my research projects in my lab. So this data still indicates that RPS19 is the most impacted in around 25% of diagnosed cases, followed by ribosomal proteins L5, S26, L11, L35A, S10, and S24. So how do these genetic variants actually cause DBA or the bone marrow failure underpinning DBA? So there's a number of different reported mechanisms, and I can't talk about them all tonight in the short time frame that we have, but I'll touch briefly on the ribosomal stress mechanism that we work on in my lab. There's also other mechanisms through translational dysfunction. So what this means is that the ribosomes or the proteins are unable to be made independent of that stress response that I talked about. Increased inflammatory signaling pathways, and also changes in the heme and hemoglobin levels. So if you can't make enough red blood cells, you have a lot of free heme that floats around. This can be toxic. So in terms of the ribosomal stress mechanism, just over 10 years ago now, and so subsequent publications have indicated that there's increased p53 protein observed in the bone marrow of individuals with DBA. So here's two pictures of bone marrow, control bone marrow and Blackfan anemia bone marrow. And so what's quite evident in some of the patients is that we have this increased p53 protein that's expressed. So what does this actually mean? So p53 is classified as a guardian of the genome, and a lot of the times it's lost in cancer. But its normal role is to actually protect cells against damage to genomic material. And so in this particular case, unfortunately, when ribosomal proteins are deficient in cells and there's reduced ribosome production, there's activation of this stress pathway through the nucleolus called the NSP, or nuclear surveillance pathway, which leads to increase in p53. And so what this does, it can cause cells to die, so they can undergo self-destruction, or they can stop dividing, which is called cell cycle arrest. And it's thought that these particular mechanisms lead to the marrow failure. So why is this important? Well, understanding this particular process in more detail will enable us scientists and clinicians to be able to find new targets and therapeutic approaches to be able to treat DBA. So a lot of the focus in my lab has been around developing different models to study these aspects of DBA. And so what we can do is we've got some really cool molecular tools that we can use. We could take human cells and we can deplete specific ribosomal proteins. And so here I'm showing you some work that we've done depleting RPS19. And so we can actually look at the ribosomes in these cells, and we can, when RPS19 is depleted, we see a reduction in the 40S subunit, which is where RPS19 normally resides. So there's a reduction here, so we can measure these changes. We can measure changes in what the nucleolus is doing, because that, as I mentioned, that's the stress sensor, so that changes when we have these changes in ribosomal proteins. And also other biochemical mechanisms and techniques that we use, such as this is a Western blot looking at the protein expression in cells. And so we see when RPS19 is deficient that we see an increase in p53 in downstream effector molecules. So based on these models that we've developed, we've been able to do a lot of high throughput screening in the last 10 years or so. This is my lab at ANU, fully automated roboticized lab. And we've been able to conduct high throughput screening in these models where we can deplete ribosomal proteins and try and understand what molecules and what genes modulate this process, so we can actually see whether or not they're targets for therapy or actually therapeutics themselves. So this is through some biomarker screening that we've conducted, looking at all the different genes in the human genome. So every individual gene in the genome we've tested. We've done some drug repurposing screens where we've looked at FDA-approved drugs. So these drugs are drugs that are used to treat other conditions, but trying to see if we can repurpose them for DBA. And also a couple of novel drug development projects that we have ongoing, but I can't really talk about tonight. So, pardon me, some of the key findings from our screening campaigns, if you like, have been really informative, and this is one of the most informative findings. So we've been able to deplete all of the ribosomal protein genes in the human genome, so as I mentioned, around 80 of those. And if we look at them individually, around 79% of those 80 proteins, many of which are DBA-associated ribosomal proteins, have increased p53. So what this means is that if we can identify those candidates which are undergoing ribosomal stress, at the specific variants that are undergoing ribosomal stress, we can actually develop and know that we can develop therapies that are going to specifically treat individuals with these particular variants. This is a busy slide, I apologise, but we've been doing some work with FDA-approved therapies, as I mentioned. So we've screened around 4,000 different compounds, and we've identified some drugs which seem to help reduce this stress response without having any negative impact on cell number. And this is a work of a couple of students in the lab, ongoing work that we're trying to understand whether or not it would be beneficial as a therapy for DBA. So of course, we want to move now more in towards being able to develop models and have more representative models of the human bone marrow environment. Human bone marrow is a really complicated organ to model in a cell culture dish. But it's really important we have these models because we want to be able to understand if the treatment's going to be effective in that situation and how it might work in individuals with DBA. And it's an important step that we need to do to enter into clinical trials. And so how we've been modelling this to date and how we're going to be modelling this in the future include culturing patient bone marrow cells. So we can actually take bone marrow and put them into culture. There are some challenges with that, and I'll talk about that in a moment. We have preclinical genetic models of DBA, and we also have a really exciting opportunity to move into the human-induced pluripotent stem cells, which I'll talk more about in a moment. But we can use these to grow bone marrow organoids, which are kind of like mini bone marrows in a culture dish, and be able to test therapies out. So as I mentioned, we have these genetic models of DBA. So this is one of several that I have going in my lab at the moment. And we actually give these mice bone marrow transplants, not to cure them, but to actually give them DBA. So we can give them DBA within the space of 8 days. And so these models actually give, recapitulate some of the features of DBA, including reduced red blood cell and reduced, this is pre-CFUE cells. So this is one of the parts, the stages of hematopoiesis, which is most impacted in DBA. And then coming back to the therapies that we've tested in our cell models, we're actually able to use these mouse models to evaluate these. And so we found that some of these drugs seem to have a positive effect, but we still need to evaluate and do more testing to make sure that they would be safe to use in a DBA environment. Just finally, as I mentioned, the hypercellular bone marrow samples can be quite challenging to grow outside of the body for a number of reasons. Even normal bone marrow is quite difficult to, I say normal, I say healthy bone marrow is really challenging to grow outside the body. So this has really limited the types of research that we've been able to conduct in patient samples. So we're trying to overcome this now by reprogramming skin or blood cells, which we take from individuals with DBA, and we reprogram these into stem cells. So they don't have any specific cell type. They are a stem cell, and we can push them towards any different type of cell type that we would like to study. And so in this case, we could push them towards becoming blood cells, and we can use this to model key aspects of the bone marrow. So there's some really exciting developments in this space. There's work that we're trying to establish this type of technology in Australia, and got some grants under review at the moment. We've also got some international collaborators that we're working with to help establish this as well. Just finally, I just wanted to touch on, I recently went to the Euro DBA meeting in Madrid. Of course, we talked about these iPSC models, but findings like single cell sequencing to look at gene expression in bone marrow cells was a hot topic. This is to help identify different clones in the bone marrow, but also trying to understand whether or not there's specific therapeutic targets that could be examined. The concept of somatic reversion came up a few times, gene editing and gene therapy for individuals with DBA, and also DBA and cancer risk. And so with that, I'd like to thank my lab, my collaborators at ANU, nationally and internationally, and of course our funding bodies, such as Maddie Rewatt's Vision, Captain Courageous Foundation, who are now part of Maddie Rewatt's Vision, who really helped to be able to fund our projects so that we can attract funding from our government, so NHMRC, and so we can have long-term research programs and impacts in this space. So thank you for your attention. I'm happy to take questions either now or later on, perhaps later on, that might work better. Okay, thank you.
Thank you so much, Amy. That was really fantastic and really exciting, of course, to hear about some of those those developments. And you mentioned there about the, one of the hot topics being gene editing, and I'll let the group know that we will have a session on that in September with some other leading experts. So you'll find out some more information about that in the near future. And a special thank you to Amy, because she has just come out of the dark hole of writing a medical research future fund grant, which we've all lived, and it's a really, really hard slog. And we're really proud to have been part of that as a partner organisation, and really wish you and the team all the very best in getting some, fingers crossed, some really good news there with that fantastic application. So Amy, thank you so much.
Thank you. Thanks.
And I now have the pleasure of introducing Dr. Patty Barbaro. So Patty is a paediatric haematologist at the Queensland Children's Hospital in Brisbane. Patty undertook his haematology training at the Children's Hospital at Westmead and has worked as a locum haematologist at both the Children's Hospital at Westmead and the Royal Children's Hospital in Melbourne before taking up the position at the Queensland Children's Hospital. So we're absolutely thrilled to have Patty here with us tonight, and he'll be presenting on treatment options for Diamond-Blackfan anemia. Over to you. Thanks so much, Patty.
Patty, you're on mute.
There we go. Is that better? Can everyone hear me now? Perfect. Yes.
Thanks, Patty. Excellent.
So thank you to Maddie Revolt's Vision for letting me talk today about Diamond-Blackfan anemia, and thank you everyone for coming. So I would like to get my screen moving. There we go. Also pay my respects to Aboriginal elders and Torres Strait Islander elders. And in Brisbane, we're on the Yagara and Turrbal people's lands. So I'd like to pay my respects to them. So I wanted to start off by talking about, what is Diamond-Blackfan anemia, because I think it has changed a lot over the last 25 years. So when I started hematology, 25 years ago, a child with Diamond-Blackfan anemia was easy to diagnose because they were young, they were less than 1 year old. They presented with anemia, which is very low hemoglobin levels. Their red cells were very big, much bigger than they should be. And then when we did a bone marrow biopsy, we found that they didn't have all of the cells inside the bone marrow that made red blood cells. And this is a picture of bone marrow. And all these dark round cells here are the cells that should make red blood cells. And these pink cells in the middle, these are all the healthy red blood cells. These other cells are white blood cells, or the cells that make white blood cells, and they form your immune system that fights infection. So in Diamond-Blackfan anemia, these small, round, dark cells are just not existent. So it was very easy to diagnose Diamond-Blackfan anemia in a child back then because we didn't know about ribosomes. We didn't know the genetic basis of Diamond-Blackfan anemia. And when you look at the timeline of Diamond-Blackfan anemia, it was first described in the 1930s by, Louis Diamond and Kenneth Blackfan, who were the two doctors who gave their names to the disease. And really, it wasn't until 1999 where the first gene was discovered that caused Diamond-Blackfan. And since then, many other genes, so over 20 genes now, are known to cause Diamond-Blackfan anemia. So with the genetic revolution, we've now kind of got ourselves a little bit confused, because there are a lot of patients with classic Diamond-Blackfan anemia that I knew 25 years ago, but there's now a lot of patients who don't fit into that classic Diamond-Blackfan phenotype. And what do we call those patients? And some of these patients might present very late in life, so not as a child. Some of them don't even have anemia, so their full blood counts and hemoglobin levels are normal, but they have genetic changes that you think should give them DBA. So in the last iteration of the international consensus guidelines, they've developed a new term called DBA syndrome, which encompasses both classic DBA, so the DBA I learnt about 25 years ago, but it also encompasses those patients who don't quite fit the classic DBA phenotype, but might have one of these mutations in a gene that we know causes DBA. So there's a lot of patients now who may not have been called DBA previously who now fit into this DBA syndrome. And a lot of the problems that patients face with classic DBA and these other DBA syndromes, they overlap quite a lot. And the more I see patients with DBA, the more I realize that every single DBA patient is very different. So there's no real classic DBA anymore, because every patient has very slightly different problems. And that could be partly because of the gene that is mutated in each individual patient. So as I said, there's over 20 genes now known, and they all may present slightly differently. And even the changes within the same gene can be different. So all that can be very different. So DBA, the name now has kind of evolved, and it's probably including a lot of patients that we didn't previously. So I'm going to talk a lot more now about treatment of DBA. And I wish I could say that we've come a long way in 50 years, but really we haven't really come that far. So again, looking at the timeline, back in the 1950s, it was found that steroids, so prednisone, treated a lot of these patients with DBA and fixed the anemia. Then in the 80s, the first bone marrow transplant for DBA was given. And really, there hasn't been a huge advance in treatments until probably, the last 20 or 23 years. And that's not to say people haven't tried. They've definitely tried lots and lots of different medications and treatments, but nothing seems to have been as successful as, steroids or bone marrow transplant. So what are the treatments for DBA? Well, currently, really, there's treatments that are designed really to fix or help with the anemia. So anemia is the low blood cells, the low red blood cells that DBA patients get. And there's a few different treatment options for DBA. One is to try and stimulate the bone marrow. The bone marrow is where all of our blood cells are made, including the red cells. So that there's treatments designed to try and stimulate the marrow to produce more red cells. And the main one we use is prednisone. As I said, we've been using it for 70 years in Blackfan anemia patients, and we know that it does work in over 80% of patients. So over 80% of patients, the hemoglobin level and the reticulocytes, which are the very early baby red blood cells that come out of the bone marrow, they go up with high-dose prednisone. Unfortunately, prednisone has quite a lot of side effects, and many of you patients who have been on prednisone for a while probably know better than anyone else about these side effects. So in children, we worry about the problems with growth and development. We worry about weak bones, because if you're on prednisone for a long time, it can weaken your bones. It can cause eye issues like cataracts, can give you high blood pressure, diabetes, reflux, and stomach ulcers. And steroids really can dampen down the immune system, so you can be prone to getting infections. So we'd like to use prednisone at a very, very low dose if we can. And with prednisone, we start at a very high dose, which gives you mostly many of these side effects at those high doses. And we try and wean the prednisone down to a very, very small dose that keeps the hemoglobin at a relatively normal level, but doesn't give you side effects. And that can happen. Probably in about 50% of patients, they respond to prednisone, and you can get them down to a low dose that doesn't cause too many side effects. But if prednisone doesn't work, the other treatment option that's the mainstay of treatment is regular red blood cell transfusions. So this is where we just give the patient the red cells they can't make on a regular basis. So transfused red blood cells, they only last about 4 to 5 weeks in the blood once you've transfused them before they disappear. So to keep a patient with DBA at a normal or a good hemoglobin level, patients often need transfusions every sort of 3 to 6 weeks, depending on the patient. So this can be tricky because they need to have a cannula and put in a vein, and often in very little kids that can be tricky, and we often have to use things like portacaths, which are permanent devices that sit under the skin so that we can give the transfusions through. The main problem with regular blood transfusions is every time we give a blood transfusion, there's a lot of iron in that transfusion. And humans are not very good, well, we are not very good at all at getting rid of excess iron. Once the iron's in our body, we have no way of getting rid of it. And all that extra iron from transfusions builds up in the body. And over many, many years, if you don't get rid of it, it can cause problems with the heart and the liver and many of the hormone organs. So it's important that if you are on regular transfusions, your iron levels, your ferritin levels get checked regularly. And nowadays we're using more MRI scans, which can measure the exact amount of iron in the liver and the heart. And that's a better indicator of patients' iron overload than the ferritin levels. Unfortunately, those scans aren't available everywhere, and they're not rebatable on Medicare, so patients don't have access to them depending on where you live. Because of all this extra iron, you need to take medicine to try and get rid of the iron. And we do have 3 good medicines these days. 2 are tablets. Jadnu is the main one that's in use because it's a once-a-day tablet. Feriprox is the other tablet that you have to give 3 times a day. And we have Desferal, which has been around for a long time, but it has to be given under the skin very slowly over 10 to 12 hours at night time. And all of these medications have side effects which need to be monitored. The transfusions in Australia, thankfully, are very safe. So the chances of getting a virus like HIV or hepatitis C in Australia is very, very low. And the way that Lifeblood processes the blood from donors also means that transfusion reactions like fevers or rashes or allergic reactions are very, very low these days. Patients sometimes can see the blood transfusion as something foreign because it is coming from somebody else, and their immune system can attack those red cells. If that happens, it can cause a bit of a problem with future transfusions. So we'd like to give patients with DBA much better matched blood than we would other people, just so that that doesn't happen. There are or have been a lot of other medications tried to try and stimulate the bone marrow. I think one that's probably shown a little bit of promise is something called leucine or L-leucine. That's one of those amino acids that Amy was talking about, which are the building blocks of proteins. And leucine can stimulate the cells to produce more proteins. There was a small study which showed quite a good response to leucine in DBA patients. So there was a bigger study in 43 patients, mostly children, but there were many adults in this study, hoping that this would, make patients transfusion independent. So all these 43 patients in this study were on regular blood transfusions. Unfortunately, well, fortunately or unfortunately, so 2 of those 43 patients were able to get off blood transfusions while they were on the leucine, and another 4 patients were able to reduce their transfusions, not to 0, but reduce them a little bit. So 6 out of 43 patients had some sort of response. The other patients, it didn't make any difference to their transfusions. But for children, it seemed to improve their growth. So up to 40% of children who were taking leucine in this study with DBA, they actually grew better. So their height and their weight went up more than expected. So this was a study done in transfusion-dependent patients, so patients on regular blood transfusions, and there's another trial ongoing, which is in DBA patients who are on long-term steroids to see does it have an effect. In Australia, leucine's a little bit tricky to get. So pharmacies don't keep it because it's more of a supplement. It's not really a medication. And there's no drug company that is making it in large quantities. So it's quite difficult to get through pharmacies. And I've had a few patients who have bought leucine on the internet through supplement websites, which is always a little bit tricky because you just never know, what you're getting. but it is available through those websites. And, if you're thinking about it, talk to your doctor about it to see, can they access it through their pharmacy? Another drug that's interesting is eltrombopag. So this is a medication that stimulates the bone marrows to mainly produce platelets, which are other cells in the blood that help stopping bleeding. But eltrombopag's been used in another bone marrow failure syndrome called aplastic anemia, and it seemed eltrombopag stimulates stem cells, which are the baby cells in the bone marrow, to just grow and make other blood cells. So it was thought there was a case of one patient with DBA who was on eltrombopag and again became transfusion independent. So it was studied in a smaller study this time, 15 patients, but again, only one had increased hemoglobin levels. And a lot of the patients had to stop because their platelet count went up very, very high. And when that happens, we worry about blood clots forming. So lots and lots of other medications have been tried, but they don't seem to be as effective as steroids or blood transfusions in many patients with DBA syndromes. And that might be that, as I said, each patient with DBA has a different gene mutated and a different mutation even within that gene. So trying to find a medication that will help all patients with DBA has been tricky, and hopefully work like the work that Amy's doing, will find something that will stimulate those ribosomes and stimulate red blood cell production. So if we can't fix patients themselves, we can give them a new bone marrow, and that's called a bone marrow transplant, also called hematopoietic stem cell transplant or just stem cell transplants. So what are stem cells? Stem cells are amazing cells that live inside the bone marrow. So inside the hard bone marrow is inside the hard bones is the bone marrow where all the blood cells are made. And you can think about stem cells as being tiny little baby cells that can divide and create more baby cells, or they can grow up to more mature blood cells. And this is the sort of picture that hematologists like to look at. And up here, right up the top, we have the stem cells. So they can divide and create more stem cells, but then they can mature into all of the cells in the blood that we know about, including the red blood cells. So this line here is all of the cells that make the red blood cells. And in Diamond Blackfan, this doesn't work, usually because of the ribosome problem in the cell. So we can fix the patient's anemia by giving them new stem cells. And that's what's called a bone marrow transplant or a stem cell transplant. So the process of a bone marrow transplant, first you have to identify a healthy donor that matches the patient's immune system very well. We look at 10 different genes to try and match them as best we can to try and stop some of the complications. We take the stem cells from the patient and then from the donor, and collect them in the lab. And the stem cells kind of sit in a bag that looks like a blood transfusion. Unfortunately, we have to kill off the patient's own bone marrow cells. That's to make room for the stem cells, but we also have to kill off their immune system so that the immune system doesn't see these new stem cells as something different or foreign and attack them. So the patients get chemotherapy to basically wipe out their bone marrow and wipe out their immune system for a period of time until these new bone marrow cells start to take shape and they start growing and making new blood. So unfortunately, there's probably the chemotherapy that you give usually takes about a week to wipe out the bone marrow, but these new stem cells usually take 3 to 6 weeks to start growing and making more blood. So there's a period of a few weeks where patients are in hospital for those weeks where they don't have an immune system. So they're at high risk of infections because of their immune problems. They're also at risk of graft failure where if there is any immune system left in the patient, they can attack these stem cells and kill them off, not allowing them to grow inside the bone marrow, and that's called graft failure. But there's another problem called graft versus host disease where the new stem cells grow in the patient and make a new immune system, But this new immune system sees the patient as different and starts attacking the patient. And that can affect the skin and the gut and the liver and the lungs. And that's called graft versus host disease. Unfortunately, if graft failure or graft versus host disease develop, the treatment is to dampen the immune system down with more drugs, and that can lead to infections. So there is a risk with bone marrow transplants, probably over 10% of developing one of these bad complications. And there's probably about a 5% risk of actually dying from one of these complications of a transplant. So if it works, it's amazing. So if it works and there's no complications, the anemia is completely fixed. Unfortunately, we've spoken about some of the short-term problems, but the chemotherapy that you give can cause fertility issues in the patient. So they may have difficulty having children later on in life. And the chemotherapy, as well as the DBA, can increase the risk of other cancers later in life as well. And then there's lots of other problems that can happen after a bone marrow transplant. But the transplant doctors are getting very good at dealing with all of these complications. And 20 years ago, we would only think about a bone marrow transplant in a Blackfan anemia patient who was young and who had a brother or sister who was a perfect match. Nowadays, because the transplanters are better, you might consider it in an older patient and one who maybe doesn't have a brother or sister, but has an unrelated donor out there who does match really, really well. So when to consider a transplant? Well, if prednisone is not working, or if you need very high doses to keep your hemoglobin high, if you're needing regular transfusions, especially if you're having trouble keeping your iron under control, if some of the other blood cell lines become affected, or if there's any changes to suggest early signs of blood cancer like leukemia, you should consider it. Obviously, you need to have a good donor that matches you very well to even consider it. And we know the younger you are, the better you do with transplant. So if you're below the age of 10, you do very well. The older you get, the more chance of having one of these complications. So the earlier, the better. So what's the future for treatment for Blackfan anemia? Look, there's a lot of people talking about gene therapy, and gene therapy is kind of like a bone marrow transplant, but instead of trying to find a donor that matches the patient, you actually collect the beautiful stem cells from the patient themselves. You take them into a lab and you either insert the ribosomal gene that's defective in the patient. So you insert a new gene that actually works normally. You grow those stem cells up in the lab, and then you transfuse them back into the patient. So it's kind of like a bone marrow transplant, but you're using the patient's cells. So there's no risk of rejection and there's no risk of graft versus host disease. So you don't have to worry about treating those things with immune drugs. Also, you do have to give a little bit of chemotherapy at the moment with gene therapy, but it's less intense than with a bone marrow transplant. So some of those other complications, like fertility, they may still be a problem at the moment. So this is still experimental in DBA. They haven't tried it in humans yet. They have shown that it works in some mouse models of DBA. And other gene therapies have been used in other blood problems. So things like thalassemia and sickle cell disease, which are also red blood cell problems. There's gene therapy products that are now licensed and being used in Europe and the United States. So hopefully over the next 10 or 15 years, we'll see a gene therapy product for Blackfan anemia coming to Australia. So there's still a few problems with gene therapy and things we don't know about. So will the new stem cells that we've put back in, will they last a lifetime? We think they will, because stem cells should last forever, but we don't know. And what do we do if the new stem cells don't last? The other concern with gene therapy is we're mucking around with patients' DNA. Will that lead to cancer later in life. And the new techniques that you're using with gene therapy hopefully means that that's not a problem. So Diamond-Blackfan anemia syndromes are not just anemia. So patients often have other problems associated with their syndrome, and that could be other blood cells could be affected, but they also have problems with growth, development. They may have been born with a cleft lip or palate, heart disease, kidney disease, sometimes bone abnormalities or eye abnormalities. And these things mean that some patients with DBA syndromes need to see other doctors to help out with these problems, both in the short term and the long term. So I think we shouldn't forget those other problems besides anemia that patients with DBA have, and we should make sure that they get the treatment they need for all of their issues that they have. I'm just going to talk a little bit about cancer risk in DBA, because we do know that patients with DBA do have a higher risk of getting cancers compared to the general population. Some of these are blood cancers, but other cancers like bone cancer or bowel cancer are also a little bit more prevalent in patients with DBA. So the new recommendations really talk about bowel cancer surveillance from a very early age. So the general population would get some sort of colonoscopy or gastroscopy from about 55 years. It's recommended that DBA patients should have those from 20 years. They should have a full blood count at least 3 or 6 months. And if there's any changes in those blood counts, they should have a bone marrow biopsy looking for the bone marrow cancer called leukemia. Unfortunately, there's no other good recommendations for surveillance for other cancers. So it's up to us to educate you guys to say if you notice an unusual swelling or you have pain in a bone, there's bruising or bleeding in large glands, please see a doctor sooner rather than later and have some tests. We're doing a lot better in keeping patients with DBA alive longer. And so some of our girls with DBA are thinking about having children. We do know that it is a little bit more difficult for DBA patients, and that's probably due to the DBA syndrome itself, but it may also be due to some of the problems with treatment. So we know that the iron chelation medication can't be used in at least the first 6 months of pregnancy. So it's really important that if you're thinking about getting pregnant and you're on regular transfusions, you need to try and get your iron down as low as you can before you get pregnant. If you're on steroids, they're usually safe in pregnancy, but again, there may be some issues with you and the baby. So if you are thinking about getting pregnant, it's important that you talk to your hematologist and you see some specialists who can help you through the pregnancy and monitor for some of these complications. I guess it's also important to consider the baby. If you know that the gene that has caused your Diamond-Blackfan anemia syndrome, the baby could also be affected with that Diamond-Blackfan. So thinking about, do you want to test the baby? When do you want to test the baby? Is also really important to think about before getting pregnant, so that you can make those choices at a timely manner. And look, I'm just going to highlight, this is the updated consensus statement. So this was a statement from lots and lots of international experts on DBA about how to diagnose and treat and do the surveillance testing for DBA patients, which only came out early this year. So this is a really good resource for any doctor who's looking after patients with DBA. So if you've got a hematologist looking after you, it's probably good to just direct them towards this because it's a very good document. And I think I've gone over time, so thank you very much for listening.
Thank you so much, Patty. Really appreciate that very comprehensive overview. And I think, certainly reinforcing why we must continue to fund the research in this space and why we must continue to advocate to government to fund in inherited bone marrow failure syndromes. And there were actually a few of those medical research future fund grants in the stem cell therapies area that we have supported that have just been submitted. And, we have our fingers crossed that there's a lot of success across the board so we can continue to push for more research in this space. Well, thank you to both Amy and Patty. We're we're so grateful for you taking the time out of your very busy schedules to share your deep expertise in this area, and we're so grateful for you taking the time to join us tonight. So